Thyroid cyst is, we're going to cover a lot of disorders in this particular video. We're going to cover some important disorders. First, let's look at the thyroid cyst. Thyroid cyst is the swelling occurring in any part of the neck, which is along the part of the thyroid duct. Now, what is the thyroid duct? This is a thyroid duct. It arises from the anterior. It arises from the foramen cecum. Obviously, it arises from the foramen cecum, which is of the posterior one third and the anterior third of the tongue, and therefore it goes down. And here the hyoid bone. Here the hyoid bone is located. This is the hyoid bone, and it goes and loops around the hyoid bone and directly goes down into below, obviously below very important thyroid cartilage, and then goes and attaches over the top of the thyroid cartilage. Now, something important to understand is that what is thyroid cyst? It's a swelling. Let's say it's a swelling occurring in any of these regions. So where does the swelling could occur? The swelling could actually occur here at the beneath the foramen cecum. It could also occur in the floor of the mouth. Obviously, in the floor of the mouth, that is out here. It could around a suprahyoid. It could be subhyoid. Subhyoid is the most common. So subhyoid is the most common, and it could also be on the thyroid cartilage, which is the second most common side. Is the second most common is going to be on the thyroid cartilage, and definitely has to be below the thyroid cartilage. It's usually congenital, and that is when there will be degeneration of part of the tract causing a cystic swelling. Now, normally thyroid may be present in the normal location, or sometimes thyroid may not be present in the normal location, but might be present in the thyroglossal cyst. Let's say if the thyroid is migrating and let's say there's degeneration of the other part of the tract, or let's say the lower part is degenerated, so then the thyroid gland itself is going to be located in the thyroglossal cyst. But usually what happens is that the thyroid gland is usually located where it is supposed to be located, on the cricoid cartilage. Here your thyroid gland is going to be located, and if this is your thyroid gland, this butterfly shaped gland, and it would be definitely located there. But what happens is that sometimes it could not be this case. It could not be the case. It is a tubular domoid type of cyst, and the entire thyroglosal duct is lined by pseudo stratified ciliated columnar epithelium. All right. Now, what are the clinical features? The clinical features, that obviously the patient is going to complain with the swelling in the front of the neck or in the anterior of the neck, which moves with deglutition. Obviously, it's going to move with deglutition, and as with the protrusion of the tongue also, because everything is connected to the cyst, the thyroglossal cyst, and it is going to have a tingling sensation, which can be felt when the examiner holds a cyst between the thumb and the forefinger. And when the patient is asked to protrude the tongue, obviously a tingling sensation can be felt. The thyroid fossa is empty if the thyroid fossa is empty if there is no normal thyroid located. Obviously, let's say if there is no thyroid here, so the thyroid fossa, it would be definitely incomplete, would be empty. But the thyroglossal cyst definitely does not mean that the thyroid fossa would be empty. It might be empty, it might not be empty. And thyroglossal cyst could also be infected. Thyroglossal cyst could be infected to form an abscess, and the abscess cyst wall contains lymphatic tissue, so infection is usually common. So let's say you have a cyst that is formed here. Let's say in the second most common site at the thyroid cartilage, you have a cyst, and the cyst can be infected, and also there is obviously presence of lymphoid tissue, which is why there could be infection. And malignancy can develop in the thyroglossal cyst. A papillary carcinoma could be developed. Obviously, there should be presence of a thyroid gland. There should be present in the thyroglossal cyst for a papillary carcinoma of the thyroid gland to occur, and the cyst will be hard and can be palpable. What do you want to do? You want to do investigation. You want to do an ultrasound of the neck. You want to do an ultrasound of the neck. You want to check if there is a cyst. You want to do an FNAC. You want to do fine needle aspiration from the cyst. You want to see a fine needle aspiration so that you could see if there is a papillary carcinoma of the thyroid that is in the abnormal location, or also you want to see the cytological features of the cyst. That's all what you could do. And if you want to do a treatment, the treatment is something called as a cyst trunk operation. How do I remember? A sister gets a sister and her trunk. So let's say something like this. So this looks the sister, one of my sisters, in her trunks, and her trunks is something I like to think of this entire diagram as a trunk. It's just a very stupid way of remembering cyst trunk operation. So what we actually do is that, let's say if this is the throat or this is the neck, we make a transverse incision, and then we go around the hyoid bone. And let's say if here is the hyoid bone, we go around the hyoid bone. And I hope you understand that the cyst is somewhere is usually subhyoid. So let's say if we go around the incision and there's going to be here a cyst, a thyroglossal cyst, what we do is that we cut cut the cyst. We cut the cyst with the surrounding. We obviously use a retractor to move the glenohyoid, mylohyoid, all the muscles that are located from the sternum and from the hyoid to the tongue and so forth and so forth. We make sure that we cut those muscles, and we separate those. We retract the muscles, and then we remove the cyst along with some part of the with the hyoid bone, also with some part of the hyoid bone, and we use this, and we keep the fascia over the cyst intact so that we do not actually rupture the cyst. Even if we rupture the cyst, there's not a lot of complications, in only in case the cyst is infected. Now let's go to another very important disorder that's called as thyroglossal fistula. Thyroglossal fistula. What is the thyroglossal fistula? It's not a congenital syndrome. It's acquired. It either follows it follows after the infection of thyroglossal cyst, which bursts open after inadequate removal of the cyst. It's lined by columnar epithelium, because I told you that it's lined by pseudocertified columnar epithelium and discharges mucosa. So what happens is that, let's say if there's a cyst on the neck, let's say this is your neck and there's a cyst around here, and that cyst gets infected, and eventually it pushes onto the skin and then it bursts open. So obviously there's going to be discharging sinus, there's going to be discharging mucosa, and this why we call it as thyroglossal fistula. It is lined by columnar epithelium. It discharges mucus. It discharges mucus, and also because of the skin, or it's not going to discharge, as it's not going to be a big rupture on the skin. There's not going to be a big fistula. Obviously the skin folds are going to cover it, and skin fold covers it. So therefore we call it as the hood sign, because it's covering like the cap of a hood. Let's say this is the hood, and here is the fistula. So your skin usually covers the fistula part. All right, so it's not really seen, and obviously what you want to remember is that, again, you want to treat it by the cyst strong operation, because it's a very important finding that could occur as a complication of thyroglossal thyroglossal fistula. What is a lateral aberrant thyroid? What is a lateral aberrant thyroid? Lateral aberrant thyroid. Well, a lateral aberrant thyroid is a misnomer. It's not a thyroid. It's actually, if this is the neck, if there is a neck, and there is a cervical lymph node somewhere, there is obviously going to be a thyroid. Your normal thyroid is going to be here, which is below the hyoid, below the normal thyroid, and stuff like that. But what I definitely want you to understand is that there is a cervical lymph node. There's a cervical lymph node around, let's say, in the posterior part of the neck. All right, so that's a cervical lymph node. When it's enlarged, usually it appears as a thyroid, and it could be due to a papillary carcinoma of the thyroid. If there's a papillary carcinoma of the thyroid, let's say it metastasized to the cervical lymph node behind posteriorly, and it appears as a lateral aberrant thyroid. But definitely it has to be fine needle aspiration has to be done, and when fine needle aspiration is done, upon your papillary carcinoma like features are definitely seen. So that's a very important when you're talking about lateral aberrant thyroid. Now let's go to the goiters. Now what is a goiter? Goiter is just an enlargement of the thyroid gland. Now what is the goiter? Goiter in its most crude sense is the enlargement of the thyroid gland. Now, what can be the causes of the enlargement of the thyroid gland? Any idea? Is the first, there's going to be a non-toxic and there could be a toxic. So let me just write it down. It could be non-toxic and it could be toxic. Toxic basically means that it is secreting T3 and T4. Non-toxic means it's not secreting T3 or T4. What does that mean? Obviously, non-toxic basically means it's not secreting high levels of T3 and T4, not just complete absence of T3 and T4. T3 normal, but here I would write as increased. Obviously, very important points to understand. It could be normal or it could be decreased. Obviously, sorry, my bad. Let me talk about the simple non-toxic causes of goiter. Obviously, it could be diffuse, hyperplastic. It could be due to physiology. It could be due to puberty. But it could be due to puberty. It could be due to primary iodine deficiency. Let's say if there is a I2 deficiency, there's going to be a colloid goiter. Definitely going to be an endemic dietary goiter. Obviously, goitrogens, you could use a secondary iodine deficiency because of using of goitrogens. And goitrogens in particular, I'm going to call about cabbage, soybeans, etc., and hilly regions. Obviously, drugs like lithium and thiocyanates and antithyroid drugs, radioactive iodines, cyanate, radioactive iodine, which could destroy the thyroid follicles, could lead to that. And antithyroid drugs could also lead to this condition. Antithyroid drugs could also lead to this condition. So then we have something called as a colloid goiter, where there's accumulation of colloid. Colloid is basically thyroglobulin. Thyroglobulin is the protein to which T3 and T4 attach. T3, T4 attached to the thyroglobulin. Now something we have is a nodular goiter. Nodular goiter, it could also be multinodular goiter, or multinodular goiter. It's basically due to increased TSH levels. Now coming to toxic. Toxic is diffuse. It could be Graves' disease. Graves' disease. It could be multinodular like Plummer's disease. And it could be toxic nodular. And it could be recurrent toxicosis.